It's my pleasure to be with you this afternoon and to talk to you about the challenges in digital health. After Henrik Mattis beautifully paved the way last week and in this very nice series of high innovation talks, and gave us a glimpse of how the healthcare in a digital world could look like in even the near future. So I going to dive in a little bit into examples of successful digital solutions in the German healthcare system, but especially also in the challenges on the way to implementing these digital healthcare solutions. Let me get started with a short overview about my current playground. You forgot to present in the introduction. So since 2018, I'm heading the KTBW. This is short for Koordinierungsstelle Telemedizin Baden-Württemberg. And in a nutshell, we are a health innovation facilitator. We're funded by the state of Baden-Württemberg, by the Ministry of Science, and can therefore act as a neutral and independent networking platform, which is important in these areas of implementation, and function as a catalyst for digital medicine projects, but also overall for innovative care solutions, with the aim of identifying innovations and transferring them into the healthcare system. At the same time, we want to provide scientific support as well as scientific evaluation, but not only scientifically, but also in terms of cost-benefit contexts. So we try to ensure innovation, translation, very early patient involvement, data safety, and data quality. And this is what the KTBW is all about in a nutshell. And we have quite a big task at hand, which is defined by the immense challenges the healthcare sector is facing. And I listed a few of them on that list. So there are bottlenecks in medical care, not only, but especially in rural areas, which is due to a shortage of general practitioners, but also an overall shortage of skilled care workers, doctors and other healthcare providers. This is on top of the demographic changes we're facing. The population gets older and older, and with it comes more and more complex chronic conditions, which make novel therapeutic and diagnostic approaches not only necessary, rather mandatory. Digitization and digital transformation is a challenge as well, but it's also a great opportunity, especially for the healthcare sector. And there's an urgent need to better transfer and translate health innovations into the primary care setting. This is not only in digital healthcare solutions, it is in overall healthcare innovations. But this is going to be necessary to tackle these challenges. And last but not least, we all want to be prepared and have the healthcare system prepared for crisis and pandemic situations, such as the current COVID-19 pandemic. So why is it that so few health innovations reach the citizens and are so rarely implemented on the market? The first thing comes to mind is that the implementation process in the health sector is rather complex and requires a wide range of actors and stakeholders. By that graph. So to implement digital technologies in the healthcare industry, you're dealing with a very fragmented, regulated, very complex and lengthy system. And from a technology or innovation to reach the citizen or the patient or the market, you need to run through several steps or run through a jungle of different rules and regulations, different bodies like the Statutory Health Insurance, the Association of Statutory Health Insurance Physicians, which is due to the Selbstverwaltung in Germany, that not the state is running the healthcare system. It's rather these associations of healthcare providers. You need to go through rigorous regulatory processes and reimbursement discussions until you end up on the market or with the patient. And if that is not complex enough, actors and stakeholders in the health sector are even changing with digitization. In the past, it was rather simple. So there was a patient and his doctor, the patient and his insurance company, the patient and the hospital he went to. So it was a one-to-one exchange. In today's world and in the future, there are overlapping roles. Insurance companies can be healthcare providers. The patient can be specialist, and so on and so forth. So it's rather a network syncing, which makes the process even more complex. And this leads to quite a few very good innovative pilot projects accompanying evaluations, especially for cost benefits evidence, are unfortunately rarely taken into account. So we have good pilot projects, but evaluation is not on top of the list of a lot of these projects. But obviously that is key if a pilot project wants to be translated into the regular healthcare system. So what's needed here is a catalyst that speaks the languages of the different stakeholders, from innovation to the actual application, knows the healthcare context and can act neutrally to push the process of translation forward. And with process of translation, I really mean until the innovation ends up in the healthcare system. So it's not done by surrogate endpoints we sometimes use in when we talk about transfer or translation, which is, you know, a startup company or an IP right, or in the academic arena, early clinical trial. No, it has to be implemented in the healthcare context. And in Baden-Württemberg, the Minister President Kretschmann himself initiated a very nice program, which is the Forum Gesundheitsstandort Baden-Württemberg, with the goal to make innovation in healthcare tangible for the public. So to exactly reach that goal. And in that program, he combined three ministries: the Ministry of Science, the Ministry of Health, and the Ministry of Economics, and recruited basically experts in the field, a couple of hundred of experts. They set up a funding program, and at the end, 40 projects in key areas defining the challenges I just talked about are now funded and on their way to better reach that goal, and even extract strategies how to reach the goal in the future. Seeing the hurdles and the challenges, I want to give you three examples of areas in the German healthcare system and how they're fared on their way to implementation. And let me start with telemedicine. So let me give you a quick history of the milestones in establishing telemedicine applications in Germany. So it was in July 2016 that the State Medical Association in Baden-Württemberg, the Landesärztekammer, as a first Landesärztekammer, allowed temporary model projects with exclusive remote medical care. And this is basically the German terminus technicus, which is ausschließliche Fernbehandlung, which basically means telemedicine applications. It took 1.5 years for the first project in that model setting to be implemented. And the first telemedicine pilot project with exclusive remote medical care in Baden-Württemberg was Doc Direct, which was a way for patients to reach out to a physician via video consultation in case their own general practitioner was not available. And actually, it started in model regions as these projects start, and is now established over the state of Baden-Württemberg, and runs quite smoothly. In May 2018, the German Medical Association, the Bundesärztekammer, then decided to liberalize the ban on remote medical care. So, which was the basis that remote medical care is possible without prior personal contact, which was the prerequisite before. And it is implemented in 16 out of 17 Landesärztekammern. So there are still areas in Germany where it's not allowed to do video consultation without prior contact to, the respective physical contact to the respective patient. But I won't tell you which area in Germany that is. It's not Baden-Württemberg, obviously. So in 2019, the reimbursement by the statutory health insurance, the GKV, changed. And this was the crucial turn, basically. It expanded, it opened up to psychotherapeutic services. Doctors were allowed to inform about their video consultation service on their websites. So you already see the change of mindset. And telemedicine was listed in the EBM and was billable. This is basically the list of fees a physician can use to get reimbursed for different services. And this was a game changer, basically, as you can imagine. So the new rule was set up in a way that the physician could bill 80% of the insured person's average rate for telemedicine or remote medical applications. And the personal doctor-patient contact prior to that was not necessary anymore. Overall, the limitation was that respective physician could not use more than 20% of his treatments as via video consultation service. In 2020, the requirements were further liberalized or basically lifted in view of the corona pandemic, which is supposed to end at the end of 2020, but I'm sure that's going to be extended in the next year and as long as corona prevails. So let me give you some quick numbers on that. In 2017, around 100 telemedicine applications were registered by the GKV. 2019, this is before the new reimbursement rule, which was October 1st, the number was 1,200. This is still tiny compared to the approximately 1 billion doctor contacts in Germany per year. So physicians were asked for their reasons to be reluctant. And they cited technical hurdles, complexity of the topic, although technique is not the key issue here. Everybody who did a video consultation knows that it's quite straightforward. But the main reason was the unclear and uneconomical billing models, as well as the general lack of incentive to dedicate oneself to telemedicine in a busy practice, and most physicians have very busy practices. So after the reimbursement was adjusted on October 1st, 2019, the number of consultations increased up to 300%. So from a different angle, and this is a study nicely done by the Health Innovation Hub together with our Mannheim Institute of Public Health, which we cooperating quite intensely. In 2017, 1.8% of physicians in practice offered video consultation, 1.8%. In May 2020, So at the end, basically, of the first wave of COVID-19 infections, 1 in 2, so 52% of physicians in practice offered video consultation, and further 10% were about to set up that service. Patients got also more and more interested in the possibilities of telemedicine. The downloads numbers increased dramatically, and the usage rate also increased, and it was quite well accepted, which is a nice effect holding up since then. In Germany, almost 3/4 of general practitioners assume that in the future every 5th consultation will take place via video consultation, and this is a huge change of mindset. So one can say COVID-19 was an accelerator in digital solutions in medicine, but especially in video consultation and telemedicine applications. Is that the answer to our challenges? Obviously, no. It's not even the answer to the shortage of medical care, especially in the rural areas. It's a nice tool to have, and an important tool to have, and that's how we should view it. It was never physical patient-doctor contact versus telemedicine. It was rather a nice extension of the relationship a good physician should have with his patient. So we're still facing the shortage, and let me get back one slide, the shortage of medical care in rural areas. And this is a project we're working on. It's an area in northern Black Forest, and in that area, up to 40% of general practitioners retire over the next 2 years. So there is a need for innovative solutions, which include telemedicine and digital solutions. And that's exactly what we tackle here, the project called AmbiGoal in that specific region. And to sum it up, AmbiGoal is a community-based, patient-centered healthcare approach with multi-professional, digitally supported teams. So those teams now are the new general practitioners 4.0, which are strictly community-based, have this social aspect GP had in the past, but they need to be digitally supported because all the patient information is not in one brain, as it was with the classical GP who treated the whole family from grandparents to the babies. So one challenge is to get the right patient information at the right time to the right person at the right location, since a whole team is taking care of the patient and not one single doctor. And the team consists obviously of physicians, but also physician assistants, nurse practitioners, social workers, physiotherapists, and so on and so forth. So this is one area where in which digital tools can help a lot in providing the data at the right time to the right person at the right location. But you can also imagine, having the physician assistant on the round of home visits, visiting chronically ill elderly people, and one of those persons might have a complicated wound, and with digital tools like a VR lens or VR glasses, the physician assistant can immediately demonstrate to the physician at the office or to the wound specialist and the wound service how that wound looks like, and the physician can direct the physician assistant, where to take specimens, how to treat, and so on and so forth. So giving you one glance of how the tools could be integrated in such a patient-centered healthcare system. This is another example how digital applications, this time not in general practitioner care, in specialist care, can work. And also an example how stakeholders all of a sudden become providers. So this is a program, at least in part, initiated by the AOK, which is the major statutory health insurance company in Germany. And the AOK, together with a project team from the University of Tübingen and general practitioners in the Tübingen area, implemented a teledermatological consultation service in general practitioner care. So the general practitioner could faster get, via telemedicine, specialists to the patient, and a faster and more effective specialist care could be provided to the patients, rather than transferring them to a specialist's office, which can take in dermatology 6 months of waiting time, for example. And in diagnosis as melanoma, this can be key. Staying with dermatology and melanoma, this gives also rise to really innovative integration of artificial intelligence in digital applications in specialist medical care. So in this study, which was done right around the corner at the National Center for Tumor Diseases, deep learning systems outperformed most of the dermatologists with different degrees of training, up to the highest training possible, in head-to-head detection of melanoma imaging classifications. So this can be a huge help in the future, especially if, as it is in Central Europe as well, and as it was in Australia, the incidence of melanoma is on the increase, on the rise. So again, this is not supposed to replace expertise of a specialist. It's a tool to help and expand the expertise to a larger patient base. So this concludes telemedicine as an example, and obviously a pandemic was the major accelerator. Let me switch to DGAS, and this is an easy task because Henrik Mattis, introduced you to the DGAS very precisely. I'm giving you the background and the history, how the DGAS evolved, and the goals of the DGAS system. So I can just, take out some points I want to make without repeating the whole context, since this was done beautifully last week. It's of note that around 73 million insured people in the statutory health insurance are eligible to healthcare through digital health applications. This is a huge market. And DGAS are the first digital solutions being prescribed by physicians and psychotherapists and reimbursed by the health insurers. And if you look at the timeline here down below, this is how fast things can go if all the right things happen at the right time. Here it wasn't a pandemic, but it was obviously the politics and the legislator who put up the right framework to allow this to happen. So the law was established in November 2019, and then all the rules or regulations could be established, including the wonderful preparation of the regulatory body BfArM to set up the stage basically for the first applications to be filed in early June. And they did set up the system in a way that they allow themselves only 3 months in a fast track to review the applications and then start the successful applications in either a provisional or a permanent directory. And from day one in that directory, the DIGAs get reimbursed, and the provider, the DIGA provider, has 12 months to bring all the evidence needed to either switch into the permanent registry, into a permanent listing position in the directory, and to start after 12 months the price negotiations with the statutory health insurance. And this slide I basically stole from the Health Innovation Hub and from last week's talk, because I think it shows nicely the variety of DIGAs and the DIGA potential DIGA applications. So DIGAs are part of the digitally enabled healthcare. If they're successful and run through that system. Do you still see my presentation? Okay, very good. So because mine is here we go. DIGA must be interoperable, safe, and patient focused. Those are 3 key requirements for the DIGAs to be listed. And as I mentioned, the fast track has a clear set of criteria for BfArM registration, and this is very parallel. And this is not by chance, because it's the same regulatory body to how drugs are reviewed before being led to the market. Although the fast track is not existent in the drug setting, at least not in that way as it is shaped here. As you learned last week, the first 2 DIGAs made it through the process from June to early October and were listed last week. This is one dealing with tinnitus, and the other one with mental diseases. And that shows nicely that the BfArM provided here a structured way for DIGAs into the healthcare system, and just as a reminder, into the market of 73 million people insured. If successful, I think this system has a huge chance to improve medical practice in the future, and especially to promote innovation. Let me finish the DIGA chapter with a reminder that key for a successful DIGA establishment in the market is to have a good evaluation concept. And this has to be submitted with the application. So it has to be very thought out early in the process how you want to evaluate your DIGA while on the list. And the evidence you generate is going to be key on 2 levels. It's key for the listing in the BfArM, which is the first step of a success story, be it provisional or permanent, but it's also key for the price negotiations later on. So one should put great thought into how one wants to generate evidence in that system.
Oliver? Sorry.
Yeah, this is Armin here speaking. Just to check whether you can switch to presentation mode.
It's not in presentation mode anymore?
No.
Okay, it's better now?
Oh, perfect now. Perfect.
Oh, sorry. Sorry for that. That's why I was asking before. It was jumping back and forth without any intervention from my side. So hope it stays that way now. Okay, but you saw everything, every detail on the slides was big enough, or?
Yes, it was.
Okay, thank you. So let me switch gears to the final chapter, the final example, which is quite a prominent one these days, since we're facing the next wave of COVID-19 infections, which is remote patient monitoring. And I took that slide from a heiINNOVATION webinar I was part of in, I guess, early June. And it clearly demonstrated that corona monitoring in the ambulatory setting is very important due to different reasons and needs to be implemented quite soon. In June, everybody was exhaling and saying, "Oh, we're very good prepared, and the first wave wasn't so bad for the healthcare system as we thought. So maybe we do not need to implement that." And that's how it went. The systems arose, but weren't implemented. Technically, they're quite easy. All the technical details are around, and a lot of providers have very good setups which could be implemented quickly. And just to give you an overview what that system can do, it's here summarized in the strategy we set up earlier the year. So it's close monitoring of COVID-19 patients in their home and quarantine setting, controlling 2 to 3 times per day via vital parameters, the pulse, respiratory rate, body temperature, level of consciousness in a score, overall general condition, and if necessary, the oxygen saturation. This can all be done via an app. And as I said, different providers have developed that setup. And on the other hand, and on the other end as well, the data comprehensively have to be provided to the doctor in the corona clinics in form of a dashboard where the doctor can see prioritized by severity how his patients fare. In Baden-Württemberg, the setup is in so-called Fieberambulanzen or Corona-Schwerpunktpraxen, which are the ambulatory centers for corona-infected people. And in such a corona clinic, doctors can quickly pick up how their patients fare and can easily, either transfer them to the hospital or keeps them in their ambulatory setting, and so on and so forth. And this is based to reduce the burden on hospitals, to better manage hospital capacity, and gives the ability to triage patients, which is very important these days. So how could that be implemented? In a stepwise fashion, obviously, in Baden-Württemberg. So initially, we want to do it in representative model regions, rural, urban, metropolitan regions. And we have an easy grasp to the situation of corona clinics and Corona-Schwerpunktpraxen in the whole state of Baden-Württemberg, since we developed earlier in the year with the KV Baden-Württemberg together a corona map, seeing the different locations and capacities of the corona clinics. So this could be an ideal test bed for scaling purposes, to scale that to the whole state of Baden-Württemberg or even further. But you see, I use the word could. It's not now, since we're facing the rise of numbers. I think the urgency is going to rise as well, and I hope we can establish that quite soon. But implementation of digital innovations remains a challenge, then even with such a timely issue as remote patient monitoring in COVID-19, we have to run through that jungle. And that should be my final slides. Stay safe.